But anyway, so good morning to everybody. And I am Dr. Arun Sharma. I am professor and head of Department of Community Medicine at University College of Medical Sciences, that is the Medical College of University of Delhi. I also had the fortune of doing my master's in business administration from Faculty of Management Studies, Delhi University in healthcare administration. And I also have interest in industrial health, occupational health, and environmental health. That is my core area of research. And I do a lot of administrative activities in my college. For example, I look after the entire information technology, procurement, logistics, and everything. I am also the chief coordinator of research in my college. And also, I look after the hostels as its provost. So, a lot of administrative and managerial work also I keep doing. And before that, I had the privilege of being director of Indian Council of Medical Research Institute in Jodhpur, which is known as the National Institute for Implementation Research on Non-Communicable Diseases, on deputation for a period of 2 years. So, with that background, let me start on the topic. The subject of today's discussion is the models of health systems used in other countries. Now, the purpose of having this particular block or this particular module in your program is that the world has different methods of delivering healthcare to the people. Some of the models for the given countries are very successful, very effective, very cost efficient. But in other countries, in spite of the model being very robust, they are not so successful in achieving the delivery of healthcare system. So this will give us an idea or an overview of how the different countries are delivering their healthcare, what are their strengths and weaknesses, and also an ability to get an insight that what works in one country may not work in other country. So probably finding solutions for a given set of conditions with the given resources, with the given geographical and demographic and socioeconomic scenario, we have to find our best possible health system. So to look at that, we will talk about, for the purpose of this session, we have taken examples from three different categories. That means healthcare delivery system of highly developed countries, and we will see the example of Denmark and Canada. For the other unit, we are taking from high income countries. Now, high income countries need not necessarily be highly developed countries. For example, if we say that Denmark and Canada are highly developed country, Germany and Switzerland are also highly developed country. But there are some countries where income levels are high, but the development level, if measured by Human Development Index or their health indicators or their educational indicators or social indicators, they have not reached that level of development. So that becomes a different scenario. And finally, the third group is the low and middle income countries where the resources are limited, the challenges are more, and how is healthcare being delivered in those scenarios. And finally, the last unit of this module is about different international organizations which work in different countries simultaneously. And how do they cope with the requirement and how do they bring global policies to the local level in different countries? That is the purpose of today's entire session. So, we start with the highly developed countries. Meanwhile, let me tell you that please note down your questions. You can write them or you can keep them with you. At the end of the session, we will have plenty of time to answer your questions and discuss the subject in detail. So moving on, first we talk about highly developed countries. So which countries are called highly developed? Which have a human development index of greater than 0.8. And the indicators which are used either in human development index or describing a country is highly developed are, for example, social indicators, So typically, in a highly developed country, expectancy of life at birth is over 75 plus years. The highest we see are to the tune of 83, 84 years in countries like Japan, Canada, Denmark, etc. High literacy and education levels, that is almost more than 98% across the country, not in a small part of the country. And then there are universal or near universal access to healthcare. And in terms of health indicator, they have low infant mortality, low maternal mortality, and communicable diseases are minimal. And finally, they have strong gender equality metrics. That means there are hardly any gender-based discrimination. Then in terms of governance, these highly developed countries have stable democratic governance, rule of law is prevailing, and the corruption levels are very low. Strong property rights and contract enforcement in favor of the citizen, and it has political stability, means it does not suffer from frequent political turmoils, unlike we see in quite a large number of developing countries in sub-Saharan Africa or the South Asian countries, which sometimes we refer to as global south. The other things that happens in highly developed countries is that infrastructures are very good, advanced transportation system, there is no deficiency of energy, and very efficient digital systems which work in telecommunication and in other fields. The standards of living are very high. They have very strong social safety net in terms of healthcare, pension, unemployment support, and other kind of benefits that are required by the people who have limited ability. And finally, the poverty rates are low. So the countries which qualify, quite a large number of them are there from Europe and North America. But we talk about primarily the most developed countries as Australia, Canada, Denmark, Iceland, Japan, Norway. The names are written only in alphabetical order. It is not in their development index order. Okay. Now, to understand the healthcare delivery system of the world, there is another approach that can be looked at. Different countries adopt different healthcare delivery models. The ones that are written here are historically developed and tested. So we have primarily three models. One is the Beveridge model, one is the Bismarck model, the third, the more modern and the recent evolution in this is insurance model. And then all these three in various combinations are used in different countries. Those are called mixed model. And then those models which do not fit into any of the above, they are grouped as other models. The number of them are very limited, very restricted. So what is this Beveridge model? This model is one of the oldest models. This is named after William Beveridge, a British economist and social reformer. And he presented a report in 1942 in which the core principle of delivery of healthcare were it should be universal coverage and it should be owned by the government and the entire healthcare delivery should be funded by the tax system of the country. And from the citizen's perspective, the most important feature of this was that it should be free at the point of use. That means when you are going to take healthcare services, either at a primary health center or a district level hospital or a super specialty hospital, you do not have to make any expenditure from your pocket. And single payer. Now, being in India, you will appreciate the importance of being a single payer. That money will flow from an independent single source to the healthcare provider. That means the government will be paying to the hospital. In contrast, if you look at developing country or Indian scenario, we have multiple sources, we have multiple payment system. For some people, the state government is paying. For some people, the employer is paying. For some people, their private insurance is paying. And for rest of the people, it is an out-of-pocket expenditure by the person who is seeking healthcare. We will go into more details of that later on. First, let us concentrate on this beverage model. Now, what are the advantages of having this beverage model? It has equity. Equity means that the healthcare which is being provided should not be based on the person's ability to get the healthcare, but it should be on the basis of the need of the healthcare. That means a person is rich, so he has more money, so he will get better healthcare, and a person who has less money will get a poorer healthcare. That is against the principle of equity. If there is a serious condition, if a serious health condition, then irrespective of your economic status, irrespective of your literacy status, you should get the best possible care for your health need. That is what the principle of equity is. Cost efficiency. Cost efficiency, you understand better being students of management. You know that cost efficiency will mean that with minimum input, we get the maximum output. That means the money is utilized in the most efficient manner to deliver the services. There should be, and the other advantage, no financial barrier, as we already said at the point of administration, no administrative hurdles. You might have heard of stories, though they are becoming less and less common, that the patient has been taken to the hospital, and then at the time of admission, first the hospital, some of the hospital, they will confirm whether your insurance is valid or not. In the process, they will ask the insurance company. Insurance company will take its time and it will get back in telling you that yes, the person is adequately insured and what all is covered. Lot of time is lost there. That may be very critical time in emergency condition, and that is a kind of an administrative hurdle. And on the other end, administrative hurdle at the time of discharge. Till the insurance company has cleared the dues, the person will not be given discharge. Now that can take 2 hours, that can take 4 hours, that can take 8 hours, which is a harassment for the patient. So in this model, because it's a single payer system and the payment is made by the government, and at the point of care, there is no hassle of paying, administrative hurdles are not there. And the access is universal. There's a difference between universal access and equitable access. Equitable access, I said, that it does not take into consideration the economic, social, or gender disparities. Universal access means whichever, I'm sorry, somebody wanted to say something? Okay. So universal access will mean irrespective of where you are located in your country, whether it is a very remote rural area, or you are in a slum, or you are in a highly advanced city, wherever you are, access to healthcare will be there for you without any hindrances. And one of the best models says that a tertiary healthcare facility must be available within 15 kilometers of every person's reach as the definition of universal access. But here comes the limitations of the beverage model. That means it proves that the model is not a perfect. And what are those limitations? In countries which have adopted beverage model, which are working on a single payer system provided by the government, free at point of service, unfortunately, for scheduled treatment, non-emergency treatment, sometimes the waiting period is very long. The patients have to wait an irreversibly long waiting time. And the second issue is flexibility. You do not have the flexibility. Whichever hospital is assigned, whichever time slot is assigned, wherever you have to go, at whatever time you have to go there. There is no flexibility in opting for a different treatment possibility as it is run by a administratively straight-jacketed system. And for this model to be successful, it depends on the government, and the government's policy becomes very crucial. Over a period of years after the execution of the beverage model, some countries have faced economic crisis because of global economic crisis or global changing scenarios or changes in the economic conditions of a country. Funding becomes limited. When funding with the government becomes limited, this beverage model does not remain sustainable and does not have the same cost efficiency with which it was started. So these are the limitations. That's why beverage model is not a foolproof model. Remember, healthcare delivery, none of the model is a foolproof model. If there was one single foolproof model, then there was no need of having other models. Therefore, we have to deal with different models which are working or which are prevalent in different parts of country. Now, let us take this example how this beverage model is applied in one of the most developed countries, that is Denmark. Let me also share with you that Denmark is the first country in the world which created health record of every citizen way back about 20 years ago. When every citizen's health record was digitized, it was available and accessible to the entire healthcare delivery system. They were the first to achieve. And as you know, Denmark is a Scandinavian country in the northern hemisphere, with its surrounded by, say, Norway on its north and Western Europe, that is Netherlands on south, United Kingdom on its east, and primarily Finland and Russia and other countries on its northeastern side. Now, let's have a look at Denmark. What kind of country it is? According to 2023 data, the population of Denmark was 6.02 million. The median age of that country at that time was 41 years. If you compare with India, we are a young nation, we are a younger country. Our median age is much smaller than that. Expectancy of life at birth, which is a very key measure of healthcare delivery system, varies between 79.74 years for men and 83.71 years for women, and average expectancy of life being 81 years. It's a very wealthy and well-to-do country. The GDP, the gross domestic product per capita on a purchasing power parity basis is $88,700, and they are ranked ninth in the world. If you look at their key health indicators, infant mortality rate is 2.61 per 1,000 live births, and maternal mortality rate is only 4 per 100,000 live births. This gives you an idea or the comparisons that how good is the healthcare delivery system, that their infant mortality is 1/10 of what is there in our country, and the maternal mortality rate is only 1/50th, rather I will say 1/25th as of now of what we are having the maternal mortality rate at this point of time. So how is healthcare delivery system works on in Denmark? The country at the national level, the government sets the regulatory framework for health services, and it is in charge of the general planning, monitoring care quality of care, and licensing of healthcare professionals. These are the tasks which is performed by the government at the central level. And it also collects taxes and allocates funding to regions and municipalities. So you have to understand that the country is divided into regions, and within regions there are municipalities. So the delivery of healthcare, primary healthcare and even secondary healthcare is delivered by the municipalities at the local level. And like states, they have five, like we have states, Denmark has 5 regions. So every region has a regional government, and regional government is responsible for delivery of the healthcare for its entire region. Okay. And 4 key national agencies are created which support that. What are these agencies? One is Health Authority, which formulates the clinical guideline and responsible for monitoring the quality of healthcare system. The second agency is the Medicine Agency, which is responsible for procuring and distribution of drugs, giving access to the drugs, importing, manufacturing, and distributing to the point of delivery of healthcare. And they are also responsible for maintaining the pharmacovigilance across country. Then third authority is the Patient Safety Authority, which looks into complaints, compensation, and kind of a medical audit and safety medical audit they perform, that if there are any errors, then how to rectify them and what to be done in order to ensure absolute safety of the patient. That is that is the responsibility of the Patient Safety Authority. And finally, they have a Health Data Authority, which is responsible for data collection and maintaining the digital infrastructure for healthcare delivery in the country. We are rapidly progressing towards digitization. Our ABDM, Ayushman Bharat Digital Mission, is very fast converting our records into electronic health records, and we are improving digital and internet-based healthcare delivery through telemedicine, through e-Sanjeevani program, through Telemanas program. So we are now also gradually moving towards that. But countries like Denmark have well-developed system of digitization of data as well as digital infrastructure for delivery of healthcare. I already said there are 5 regions, and in each region, they own, manage, and finance the hospitals. The money comes from the central government to the regions, and dispersal is done by the regional governments to the regional governing council to the hospitals. They do not generate revenue. Revenue comes from centralized taxation system. Okay. Then municipal levels, each region is divided into municipalities, and across country there are 98 municipalities, and they are responsible for financing and delivering nursing home care, home nurses, health visitors, some dental services, school health services, domestic patient care, or what is known as the in-house care, treatment for substance abuse, and also carrying out the public health and health promotion activities and rehabilitation of the disabled people. All these activities, actual activities, are carried out by the municipal, at the municipal level by municipal agencies. So that was the overview of healthcare delivery system in Denmark. Then we come to the healthcare delivery system in Canada. Again, for comparison, Canada had a population of 41 million. Their median age is also similar to Denmark, that is 41.3. Their life expectancy at birth is also similar, 83.8 for female, 79.4 for male, and the average overall life expectancy being 81.6 years. Their GDP per capita on purchasing power parity basis is similar, $54,000. Another important thing for both Canada and Denmark and other developed countries, that all of these countries spend 10% of their GDP or more exclusively on healthcare, which is very, very important if we compare with the GDP that is spent on healthcare in India and developing countries. Okay. And their infant mortality rate is very good, again, 4.7. Maternal mortality rate is relatively high compared to, say, Denmark, which is around 12 according to 2024 data. Now, how is healthcare delivery system of Canada working? Canada's healthcare delivery system combines universal public insurance for essential care with provincial control over delivery. So like Denmark is divided into regions, Canada is divided into provinces. Provinces are similar to our states. And here, there's a mixed public-private arrangement for services. For example, now in Canada, the government is responsible for delivery of health services, but private practice or private healthcare facilities also exist. That means independently people provide healthcare, but those are not to be paid by the people from their pocket. The payment will come from the government. And because in recent years, that means in last 10 to 15 years, the Canadian healthcare delivery system has become overburdened and they are not able to cope with the requirement of the services, and there are long waiting time and there are limited facilities available. So now Canada has to shift their model from a purely beverage model to a mixed model. As a result, what has happened? Private insurance companies have also come into picture, and private setups are being encouraged by the government to meet the healthcare need of the people. Okay. The system is decentralized, so service design and waiting time can vary across provinces and territories. Canada also provides special health services for veterans, war veterans, they mean, refugees, federal prisoners, active military personnel, and First Nations and Inuit population. That means these are the local, tribal, aboriginal population. For them, care is exclusively provided by the government. They do not have to depend on the private sector. But for example, in large multinational companies have started insuring their employees and their dependents. So some part of healthcare is financed by the private insurance system also in Canada, because the government could not cope with the entire requirement. So the original system, the structure is like that it is publicly funded through taxes again, just like in Denmark, and it provides coverage to eligible residents of each province or territory. Provincial and territorial governments are mainly responsible for organizing, financing, and delivering health services. The federal government only sets broad rules under the Canada Health Act, transfers money, regulates drugs, medical devices, food, and other health-related products to maintain health of the country. Regarding coverage, core coverage includes medically necessary hospital, physician, and some surgical dental services. Provinces and territories may also cover services such as prescription drugs, home care, vision care, dental care, ambulance services, etc. And services not insured under public plans may be paid out of pocket or through private insurance. That is what I was talking to you about, that now people can buy healthcare services from their personal resources, or people who are employed with different private companies. The companies buy them insurance and they take care of the health needs of their employees and their family, dependent family members. Now, here, there's an interesting thing. In Canada, most providers are privately owned. There are government hospitals, there are government clinics, but majority of them are owned by private. So what happens? That for every service provided by these private companies, the government will pay them. So they are owned and run privately. But the financing of the services provided is coming from the government. And government either pays through the taxation system or simultaneously through if services are insured, it comes from the insurance system. Now, if we try to analyze the systems of these highly developed countries, that is the beverage model, what we see, what are the strengths of this? It provides universal coverage. It is free at point of care. Urgent care is given in a timely manner, especially in emergency condition. Nobody is denied treatment, or at least in emergency, there are no unnecessary waiting time. Single delegated health authority, so there is no multiplicity of agency, so there is no confusion. And primary health care is improving because more and more primary health care are being set up. What are the weaknesses? There are long waiting times, especially for chronic ailments, for planned surgeries, and for routine services. The waiting times have become, in places, sometimes they have become very long. Access, unfortunately, is inequitable. There is a large segment of the population, not very large segment, but a substantial number of people do not get access because there are remote, difficult to reach areas in Canada. You might be aware that Canada, in terms of its size, is a very large country, and there are northern hemispherical areas which are not very well developed, where infrastructure is not very good. There, the services are not as accessible as in the southern part of Canada. And uneven distribution of human resources. As I said, that in remote and far-reaching areas, nobody wants to set up their clinic. Just like in India, you see that people prefer to set up their services in urban areas. They do not like to go to the rural or remote areas. The same thing happens in for the remote areas of Canada also. Now, are there opportunities? Yes. Government is committed to improve primary care services. They are struggling, but they are trying to increase the reach. And the threat that if the demands are not met, if the financial condition, now that we are in a global financial crisis, there is war, there is crisis of energy. In such situation, there is a very big threat of collapse of the system. So that is in short a short analysis and an overview of the model of healthcare delivery in highly developed countries which are using the Beveridge model. Now, let us see, as I was telling you, high-income countries, I have not taken example from these countries like Guinea, Saudi Arabia, Oman, etc. They are very rich countries. Their gross national income per capita is, say, US dollar 14,000, which is much higher than even the best developed countries. But in their their healthcare services are not as good or not as competent, or the healthcare outcomes are not as good as we are seeing in highly developed countries. There is some amount of disparity there. Now let us look at the other model of healthcare delivery system, which is known as the Bismarck model of healthcare system. You are aware, Bismarck was a German economist and socialist there. He proposed this model. And this was first formal healthcare model which was introduced in Germany. This is based on the principle of employment-based funding. Employment-based funding means the government, the central government, is not fully responsible for providing healthcare services, but people who are employed in industrial sector or in any sector, the employer and the employee together will provide funds for healthcare services. So this is something very similar to what we have, the ESI system, the Employee State Insurance Corporation, which is responsible for providing healthcare to the employees and their dependents. And of course, there is a capping. There's a categorization there that employees earning only up to a certain amount of money will be eligible for ESI in India. But in the Bismarck model of employment-based funding, all employees are eligible to get healthcare services through a funding system, which is an insurance fund. And in that, employer and employee will contribute. So it's a kind of, as you are already aware, this is a kind of an insurance system where the insurance risk is pooled. All employers and all employees will contribute. A pool of money will be generated, and that money will be utilized for covering the health risk of the employees and their dependent members. Now, here the insurance is managed by non-profit competing funds but regulated by government. That means mostly insurance companies in the private sector are profit-making companies. But in the Bismarck model of healthcare, the insurance companies which are providing healthcare services are not doing it for profit. They are doing it as a requirement by the government. Authorities have set up non-profit insurance companies, but their business will come from the government sources. So if there are multiplicity of such insurance agencies, then there will be competition among them. And competition will improve quality. Competition will bring down the cost. That is why competing funds are set up by the government, and government regulates. There is a regulatory agency, like in our country, we have IRDA, which regulates insurance Regulatory and Development Authority. Just like that, they have an insurance regulation system by the central government, so that the benefits are available to the employees and their dependent through a transparent system, and there is no harassment. This model was developed in Germany, and it is followed in countries like Germany, Switzerland, France, Belgium, and outside Europe also, Japan and South Korea also follow the Bismarck model to a large extent. Now, similarly, we can have a overview of Germany, but I will ignore that. They are also spending GDP per capita of 12.4% of GDP they are spending on health. What is common to all these countries? That they spend a lot of money on their healthcare. Whether it is Germany, Switzerland, Denmark, Canada, in these countries, healthcare is a very priority area and education. A large amount of GDP is spent on health and on education, and that is why their literacy levels are high, their health indicators are good, and population is relatively healthy, and they have long expectancy of life at birth. So, going into more detail, how healthcare is delivered in Germany. There's a principle of social reconciliation. I'm not using the German term which is given in your textbook or which is given in your module. Just for understanding purposes, we have to see that social reconciliation means all members have to bear cost of healthcare management and benefits. Health insurance is statutory. You have to be part of the health insurance system. Otherwise, you cannot survive there because you cannot have any other source of getting health. And this is the principle of shared cost. It's a social responsibility. I will share the health need of my fellow community member. That is the principle behind it. So what happens? In insurance, this is known as risk pooling. What is risk pooling? Every person at every time of age, every part of their age, they're not at equal risk of any health catastrophe or health related conditions. But everybody at some point of time will require health services, right? So I'm ensuring that I am giving money to an agency today so that when I will fall sick, my health will be taken care of. And if this responsibility is distributed among all citizens, then the average cost of providing services becomes much lower. That is the fundamental principle of insurance. That out of 100 people, if they're contributing to insurance, we know by default that say maximum 10% of the people will fall sick or require care services at any given point of time. 90% of the people at that point of time are healthy. But they have given money for taking care of these 10% people. And then over a period of time, this 10% is dynamic. Those 10 people who needed healthcare services today will not need it tomorrow or day after. But they will continue to bear the cost. So next year, the other 10% people who will require healthcare services, they do not have to pay at that time. That has been taken care by the society. This is the principle of social reconciliation. Now, here the difference from the beverage model is that payment is not single payer system. As you can see, that the services provided by a mixed system of public hospitals, public healthcare delivery systems, private healthcare delivery systems, and the not-for-profit hospitals. So it's a mixture of all three systems are provided there. Besides that, there are rehabilitation centers and long-term care facilities for chronic illnesses. There are separate mental health services, and pharmacies function separately for selling medicines, but medicine supply system is monitored by the government. It is regulated. So people can buy medicines from the pharmacies based on the prescription. It is not provided as part of the care from the hospitals of the country. Now, Switzerland is an example of one of the most efficient healthcare delivery system in the world. Hospitals are both public and private, but being a small country, being having to cater for a very limited population, they have been able to do it very efficient. And easy access is there easy access is there even without referral because healthcare services are available. What I was telling you that within 15 kilometers services should be available. In fact, in Switzerland, in most parts of the country, within 5 kilometers, even tertiary care health facilities are available. Their healthcare delivery system is so well developed and so well distributed across the entire country. But here, professional may practice independently. People can set up their private practice and they can earn money by this using a license system, just like we have a medical council which registers people, which gives a license to practice. The same licensing system works in Switzerland also. Primary healthcare is delivered through private practitioners and clinics, and a balanced approach to solidarity and competition. What does that mean? In terms of competition, if you allow too many private practitioners in one small area, then the competition will be very strong and quality of care may suffer. So the government regulation do not allow any number of people to set up their clinics or private practices in an area. That is regulated. And solidarity approach means that each healthcare service is working as complementary to the other. There is competition, but still at the same time, it is not a business like competition. The competition is more at the organized level, not at pulling the patient key, come to me, don't go there, come to me, I am giving you better services, advertising and saying ki we are giving the same service at a lower price. No, that type of competition is not there. But by virtue of your quality of service, your ability, you compete with other service providers. But there will be solidarity. There will not be any kind of animosity between the service providers. And this is only possible because the government regulations are very, very strict. The punishments for violation of the rules are very strict. So usually such incidents do not happen common. That was the Bismarckian model of healthcare delivery. Now we come to the third system, that is purely insurance-based healthcare delivery system. Now, I was already describing you what is the principle of insurance, but in an insurance-based healthcare delivery system, the funding comes from, though it is insurance-based, it comes from many sources. Like it can come from government, it can come from employer, it can come from individual. Let us, to understand this, let us take this the example of United States. What happens in United States? In United States, if you go there, and even if you are a citizen, and if you are not covered by an insurance, and you want healthcare services, you will get healthcare services. But the cost is so steeply high that 95% of the population cannot afford the healthcare services offered by the private healthcare delivery systems in the country. Therefore, to ensure that you get your healthcare services, you have to fall back upon an insurance-based healthcare system. So now, in America, in the United States of America, government provides insurance. Companies, because it's a democratic capitalist country, there are multiple companies which are employing people. So employers also provide insurance. And those who do not work in this organized sector and those who are not covered by government, they have to buy their own insurance. What does that mean? Government provides health care only to the people who are belonging to a certain category. That means there are two types of system called Medicare and Medicaid. Medicaid means people who cannot earn, who cannot work, who do not have their own money. Government will insure their health care. Okay? Whoever, and other than that, senior citizens, disabled senior citizens, war veterans, they will be covered by the government healthcare service. But if you are adult, if you are free, if you are fit, and you are eligible to work, then you will work in a company, in a private sector. If you work in a company, the company will be responsible for ensuring your health. And if you are not an employee, if you are not a part of the government agency, or if you are not an eligible beneficiary of the government insurance-based healthcare system, you have to buy your own individual healthcare. That means there are private insurance companies which sell insurance packages and you have to buy that. So small businessmen, independent private chartered accountants, lawyers, other professionals who are not employed or who are not in government services, they run their own businesses. they have to buy their own private insurance. So it is based on that. Now, who provides the services? Here again, majority of the hospitals and clinics are private owned. Few hospitals are run by state or provincial governments. Some hospitals are also run by municipalities or urban area metropolitan authorities. And also, people set up their private clinics as a standalone clinic, or there is a system of managed care. Managed care means they have polyclinic system where large number of doctors give their services. Sorry, and those services are managed by a managerial system which runs those clinics. And these doctors are not employees of those clinics. These doctors are independent practitioners there. They go and they see patients, and a part of the fees is taken by the managers who manage the clinic, and part of the revenue generated is shared with the doctors who are providing services. So they are not on payroll, they are not employees. But large managed clinics and small hospitals have a employee, doctor employee or the healthcare delivery employee systems also. So that is primarily the insurance-based healthcare system prevailing, and the most practical, most popular example is from United States of America. Okay, and the hospitals are again here. There is another important component of insurance-based healthcare system that is called deductible or co-payment. Some of you must be also now beneficiaries of health insurance. You might have bought health insurance for yourself or your families, and you might see that in the terms and conditions it is written that for some services you have to bear a part of the cost. Bearing a part of the cost means if you go for healthcare services and you want to use your insurance system, you have to pay 1,000 rupees from your pocket. Rest of the rest of the expenditure will be borne by the insurance company. Now, what is this 1,000 rupees? That is co-payment. That a part of the payment you bear to make you responsible and accountable, and it has been broadly exercised or broadly implemented to prevent misuse of the insurance culture system. Because some money you are paying from your pocket, so you'll be more responsible towards using. Otherwise, there had been practice of fraudulent insurance claims in the name of healthcare delivery. To prevent that, this is done. And there's another condition called deductible. Deductible means that whatever payment is being made, a part of the payment you will have to make because that is deduced from your insurance system. That is pre-decided. When you buy your insurance, all these conditions are spelled out clearly that what amount of money you will have to pay from your own resources even if you use insurance, and what is not covered under insurance. Sometimes insurance is designed in such a way that pre-existing illnesses are not covered, or if you have hidden the presence of risk factors for certain diseases which increases the probability of the disease, then also the insurance company will not pay it, and that also gets covered under deductible. Sometimes prosthesis like dental implant or artificial denture or your glasses, reading spectacles, they are sometimes not covered by insurance. So this is the how an insurance-based healthcare delivery system works. Now, the insurance model, one of the examples of insurance model is Taiwan. In Taiwan, National Health Insurance System is a single payer health insurance program where insurance premiums are again paid by different agencies, employees and employers, or government. Now here, the model is slightly different from the Bismarck model. In Bismarck model, what was happening? That there is only one insurance. Part of the premium is paid by the employer and part of the premium is paid by the employee. Just like our ESI system. What happens in ESI system? That a percentage of salary is deducted from your payable salary as your contribution to ESI, and an equivalent amount is contributed by the employer from its fund, right? That is the Bismarck model. But in insurance premium model, what happens? Sometimes when a person is going to join a company, you are negotiating the salary with the company. And the company will say, okay, I'll give you this much salary in hand. This much will go into your social security. And this much money will go towards buying a health insurance for you. So the employer is buying the health insurance for the employee. The employee does not have to contribute. The insurance provided is a health insurance program, which is providing the insurance, but this company will buy the insurance for you. You don't have to pay. And that will become part of your pay package. Similarly, for the disabled people or people who do not have adequate income, government will buy the insurance for them. For example, we see Ayushman Bharat scheme in India, where the senior citizens above the age of 70 years are given an insurance cover of expenditure up to 5 lakh. Now, where does this money come from? Actually, the government is bearing the expenditure to a third party, and the third party is an insurance company. So for your 5 lakh rupees insurance cover, government is paying a premium to the insurance agency, which is responsible for bearing expenditure of your healthcare when you go for treatment in a healthcare agency, whether a hospital or a clinic or a nursing home, which is covered by the Ayushman Bharat program. So in comparison to that, in comparison to our country's model, let us try to understand that here in an insurance model, either the employer buys the insurance, or if somebody is not employed and not able, they are socially and economically dependent, government will buy the insurance. Or sometimes in the employer-employee agreement, employee says, no, give me more salary, don't give me insurance, I'll buy my own insurance. So in that case, employee fills up the insurance premium. Now in funding, there are rules of co-payment. As explained earlier, co-payment are to be borne by the people except for vulnerable population like senior citizen, unemployed people, children, and other vulnerable group. The government takes care of the co-payment and in the form of subsidy. They don't have to pay. And of course, the coverage is universal, including the traditional system of medicine prevalent in Taiwan. That is, the Chinese medicine system is also covered. So if you are taking services from Chinese medicine, just like we have homeopathy, Ayurveda, Unani, Siddha, in Taiwan, Chinese medicine system is also recognized as a standard healthcare delivery system, and the cost is borne. What is the system is technologically advanced. As you know, Taiwan is one of the most advanced technological countries. They are the hub for manufacturing most of the parts of electronic instruments and gadgets and everything. So they have been able to have 100% coverage. It's a very efficient coverage. Their digital integration is also complete. That means it's a completely digitized process. And the model, insurance-based healthcare delivery model, in this particular country is a very cost-effective model. Now, let us look at another country which falls under the category of middle income country, that is Brazil. Now, Brazil is a very interesting case study because Brazil is not a very well-established, developed, or a high economy country. Though it comes under the category of middle income country, it has a lot of struggles because of its democratic system, because of a large poverty. The poverty in Brazil is significantly high in contrast to its economic stability or in terms of its economic productive value. Right. Brazil has, like what we have slums in India, Brazil have areas called favelas. Favelas are similar to slum, where the economy is poor, where literacy levels are poor. People live in ghetto-like conditions. There are gang wars. There is lots of domestic violence. There is a lot of drug abuse, substance abuse. All kinds of problems are there. And Brazil struggles with that. In spite of that, the government tries its best to provide healthcare services even to those sectors where the economy is poor. So they have a dual healthcare system, which is a universal public healthcare system given by the government, and there's an independent private sector, again under some loose regulation, Not very strict regulation as we saw in Switzerland. The regulations are not so strict, but there is a private healthcare delivery system just like we have. They call it a unified health system, which is acronymed as SUS. They are Portuguese speaking country. This acronym is from Portuguese. This is the largest public health system covering 75 to 80% of the population, offering free access to all residents to a decentralized structure on paper. Let me remind you that 80% population is covered on paper. In reality, access to free healthcare services is not there for all the so-called covered 80% people. And it is divided into, again, federal, state, and municipality level. We have seen across entire sections that the governance structure are one federal, that is the central, then intermediate, which may be a province, which may be a region, which may be a zone, and finally the local level, which is the municipal level. The private sector accounts for 25% of the Brazilians' access of healthcare through insurance, again, obtained either from insurance from the insurance companies or by the provided by the employer. Now, of the Brazilian healthcare system, what is good about it? Immunization coverage is very good. Brazil is one of the countries where HIV infection rates in the 1990s and subsequently were very high. And HIV positive people and frank AIDS cases, the numbers were very substantial. And in the earlier stage, if you follow the healthcare system, in early 2000, in the starting of this millennium, Brazil was struggling with providing AIDS treatment to up to the AIDS patient in the country. There was a lot of agitation, there was a lot of violence. The government became unpopular because it could not afford the AIDS treatment at that time. But they gradually strengthened their healthcare delivery system, and even costly HIV/AIDS treatment is now made affordable in Brazil by the government's healthcare system. And they've been able to achieve a very low level of IMR and MMR, not certainly as low as in developed countries, but their levels are definitely better. What are the challenges the Brazilian healthcare delivery system faces? This has chronic underfunding, there is shortage of doctors, and in the private sector, the cost of expenditure or cost of income, cost of delivering healthcare is very high. The other example I would like to give you is from our neighboring country, that is Sri Lanka, which is again passed through a major financial crisis a few years ago. Their economy had a very serious setback, but they follow the mixture of beverage model and insurance model. This is funded through general taxation, but lower per capita health expenditure. Their healthcare delivery system is very cost efficient. So actual expenditure per capita is low. And like India, they have also divided their healthcare delivery system into primary, secondary, and tertiary level care. Community health workers are their backbone, just like we have our ANMs and ASAs and Anganwadi workers. They also have their community health workers. And the system is primarily regulated by the government. And more or less, the healthcare deliveries are good. There, they also have immunization coverage of a very good level, more than 95%. Medicines are made available free of cost, particularly in the government served sectors, and their IMR and MMR are also low. But they also suffer from problem like because of the economic crisis. Now there is a problem of underfunding, and specialist services are less available because specialist doctors are relatively few in terms of the requirement, and there are geographic disparities. Southern Sri Lanka and northern Sri Lanka have different disposition of healthcare delivery system. They also suffered from a politico-social strife for a very long time, as you are aware, because of the Tamil aggressive movement. But thanks to its subsidence and removal of that kind of violence in the country, it has become more stable. But they are now recovering from economic stress, and that is why there are disparities in delivery of healthcare system in the remote and rural areas. The last example I want to give you is from United Kingdom, because at one stage, the United Kingdom's national health services were very popular. They were a wonderful example in the world for almost an ideal healthcare delivery system. But unfortunately, that system is also now struggling. The national health services has more problem now. In the post-World War era, from 1948 to 1970s, I will say that the healthcare system, National Health Services, worked very efficiently, and the British healthcare delivery system was very good, and people could do that because there was this was a single payer system again, and it was funded through taxation. They also spend almost 12% of their GDP on health. And how the National Health Service is organized, they have general practitioners at the local level. So anybody falling sick has to go to the general practitioner first. He cannot go to a specialist services or a hospital or a super specialty hospital on their own. They have very strong referral system. Only when the general practitioner, after preliminary examination, will deem fit, he will refer the patient to the nearest available facility. And you can go there only. Person living in southern England cannot go to Ireland for treatment. Person permanently living in Ireland cannot go to Scotland for treatment. Unlike in India, a person living in Calcutta can come to Delhi for treatment, or a person living in Mumbai can go to Chennai for treatment. No, in UK, British healthcare system, it is not possible. You have to be seen by a general practitioner in your local area. Primary care will be provided there. And only if the general practitioner refers you, using the referral system, you go to the next higher level of delivery system. And then you will be taken care of over there. And the secondary and tertiary care facility are created by what is known as National Health Services Trust and Foundation Trust. These foundations and the trust develop hospitals, establish hospitals, employ doctors, and provide services of the secondary and tertiary care. But unfortunately, the healthcare delivery is now, NHS system is crumbling. NHS system is not able to keep pace with the healthcare demand of the country. The wait list is very long. Chronic patients, like in Canada, have to wait for a very long time for treatment. Staff retention crisis. A lot of people are leaving the national health services and independently working. And thirdly, the population of Britain is aging. Britain is one of the most aged country, like proportion of population which are in the geriatric age group or advanced age is very high. So the geriatric healthcare services are not keeping pace with the requirement of the country, as this segment of the population is very much increasing. So these are the challenges which the British healthcare system is also facing. On the other side, the model in its heydays was a very successful model because the services were comprehensive. They used to advertise or call it, boast about cradle to grave cover. That means from birth to death, your entire health needs are covered by single system, that is the National Health Services. There was equity of access, and there was a lot of administrative efficiency, which are historical now because now the system is crumbling. But still, at the same time, they are trying their best to manage the NHS and improve its efficacy as far as practically possible and as far as their economic systems are allowing. That is all about the a comparative understanding of the healthcare delivery system in different designs, different scenarios across the country. Right? So, for the time being, if you want, I can stop here for the time being and take your questions if there are any. Let me see if there are any questions. One way is there a chat box where questions may be present? Let me check. Well,
Sir,
no,
can I ask a few questions, sir?
Yes, sir. Yes, sir. I will come to you. Just give me a moment. Just let me see if there is any chat box where there are questions. No. Fine. So I'll take questions one by one. Please
Yes,
go ahead, sir, with your question.
yes, sir. So because United Kingdom model you described in the last, but William Beveridge was from UK itself, and so can't it will clubbed in the Beveridge model, sir?
I'm sorry. Please repeat your question.
I said the William Beveridge who
Yeah.
started the Beveridge model,
Yeah.
he was rather a citizen from
Yeah. Yeah.
United Kingdom. So can't this model of UK system be clubbed in the Beveridge model?
So, because the NHS, the National Health Services, does not strictly follow the entire beverage model, the beverage model, that
Yes,
is
sir.
why we cannot club it. That is why it is being treated independently.
So the question, if it comes up the beverage model, we cannot mention about the UK's name, isn't it, sir?
Because in beverage model you saw that it is single payer taxation system which is not working, and the referral system was not described as such in beverage model, which is an innovation of NHS. So we
Okay,
cannot
sir.
club them.
Okay, sir. So
Yeah,
question will come separately for the UK system.
that is right.
Sri Lanka, in fact, I have a first-hand experience
I see.
serving there with the Indian peacekeeping force,
Okay.
and the geographical location is such
Yeah.
that the piece of land is locked between water, that is called lagoons, and
Right.
so it's very difficult to reach any medical help to all of them uh,
Right.
in a equitable manner.
Okay.
So because the larger cities like Trincomalee, Jaffna, and
Uh-huh.
Colombo are those are the places where it is okay, but a
Mhm.
smaller places you have to travel by boat or ships
I
to reach
see.
over there. So those are the
Right.
geographical locations, and they are really division of these Sinhalese and local population Sinhalese, and then this Tamilians.
Okay.
So in fact, we were providing that time. I was there for 1 year of
Right.
Indian peacekeeping, so providing treatment from our side, but situation is really pathetic.
I
And if
see.
they have to travel to the tertiary centers, they have to use boats and emergencies. The boats may not be available during night time, sir.
Right.
So, and serving as a administrator in the hospitals, I'll tell you about the deductibles. I won't take much time, sir.
Yeah. No, please go ahead.
Consumables, medical consumables, they are not being you mean sanctioned by the insurance companies, as you told about the prosthetics and implants also.
Right.
And so medical consumables, basically the hospital charges the
Yeah.
patients.
Hmm.
Denmark, my daughter and son-in-law are staying, so I have got the first-hand experience.
Okay.
Very well-developed country, and Novo Nordics is one of the pharma company which is contributing
That's
almost
right.
25% of the GDP of the country.
I see.
They are
Okay.
producing the diabetic medicines, obesity, reducing some of the injectables like Ozempic, which was developed by there. They have been used by our celebrities in India to lose their
Mhm.
weights also.
Right.
And so that's was the about. But I'll tell you, the waiting time is very, very long over there.
That's right.
My son-in-law, he had to get a angiography done, and you
Mhm.
see, he had to wait for 3 months for that.
I see.
Uh,
Okay.
my daughter had to deliver a baby over there, and first child was born by cesarean in Calcutta.
Hmm.
And there they were waiting for. We were in fact so anxious, and they took good about 18 hours
Oh
to
my
have
God.
a normal
Okay.
delivery. So though she was being observed
Yeah.
properly, but we were worried that India it is thought that if first child is delivered by cesarean, secondly also they will do it, but they never did it. And
I
it
see.
took about 18-20 hours.
Okay.
in labor pain, but they delivered through the normal system.
Mhm.
So this was the
Right.
my in fact.
Thank you so much, sir, for sharing your experiences. I am sure for the other listeners also it will be very useful. To you have first-hand experience of Sri Lanka and Denmark, two different societies, two different economies, and
Yeah,
the healthcare delivery systems. So great. Any other friends who want to ask a question or share their experience or want to give any comment? You are most welcome to do so about the healthcare delivery system across the world. Well, I can understand that passive learning is the basic system of learning in our country. So I will
Sir, good
go
morning.
ahead. Yes, good morning. Kindly
Sir,
introduce yourself.
sir, I'm Dr. Prakash, sir. I'm a pediatrician from Andhra Pradesh, sir.
Right, sir. Welcome, sir.
Yes.
Please go ahead.
Sir, is the health delivery system in the US is far better than the remaining parts of the continents of the world, sir? Or is there any model, ideal model, or do you want to put it in a like crisp and comprehensive way? What is the best system as of today, and what else can be introduced or accommodated in the best system, and what may be the best model as of today according to the needs of the people of
Well, Dr. Prakash, good morning and thank you for asking this question.
so,
This is very, very important to understand that there is no single perfect model because the world over, if you look at, there are social, cultural, geographical, and economic diversities. All right. If there are such diversities, then the healthcare needs and healthcare delivery systems cannot be the same. The world is not such that one size fits all system can be delivered. And that is why we have so many systems. You see, the Beveridge model, the Bismarck model, the insurance model, everything has been tried. When everything has been tried, what we are seeing that for some time, say British NHS model was very successful. But after a certain time, when the demography changed, when the economic condition changed, when the country's scenario changed, the NHS system started crumbling. Canada, Denmark, these countries which achieved the highest level of health in the world, their system must have been very good. But now, as Dr. Madan Mohan was sharing his experience, that the waiting time is so long. Or if you go to Sri Lanka, the access is so difficult. That means every area has its local problems and local challenges and local resources. So what I believe that finding the best model is the responsibility of the local system. Local system should find what will work best. And it is not only local system in terms of spatial, it's local system in temporal. Temporal, I mean, what works today may not work tomorrow. For example, if you look at India of 1970s, the health needs were very different from the health needs of today. And after 30 years, when we will also have a very large proportion of aged population, geriatric population, the health needs will become very different. And as our economy will grow, we will have better and better economic resources. Then maybe we will have a different system to take care of, different system of delivering healthcare than what we are practicing today or what we practiced yesterday. So to sum up, the no healthcare system across the world can be one which can be applicable and which can be successful, and no world healthcare system can be successful across the entire time period. Over a period of time, it will require change. It will require change from place to place. I hope that answers your question.
thank you, sir. Sir, can you please
Yes.
put some of the best practices of the country what best practice of some countries that suits for our country, for India to as of today for the best healthcare delivery. Do you suggest any models, sir?
No, it is difficult
Best
to
practice.
suggest a single model. Why I say that?
Sir, best
That see,
practices, sir.
yeah, I'm coming to, okay. Best practices, it requires, I will say that one of the most important thing, the reforms, if you talk about, we need to change things. Okay.
Sir,
The first thing we need to change is make healthcare services so attractive that people are willing to go and work in the rural, remote and rural servicing areas. Right.
sir,
Now, the remote area in Punjab, rural area in Punjab will be different from rural area in Jharkhand. Rural area in Jharkhand will be different from rural area in Nagaland. So the central government cannot have the same system. It is the local responsibility to make the healthcare services so attractive for a doctor to go and willingly work in the remote and rural area. That is one reform that we need. We
sir.
cannot force people to go and work because we are a democratic country, right? But if
Yes,
you make the working conditions so conducive and so convenient that people will be attracted to go there. So, first reform that is required is management of human resources in healthcare delivery system.
sir.
Second reform that is required is a proper referral system. Unfortunately, we do not have a referral system. Anybody can go into any hospital or any place for taking treatment. A tertiary care hospital, unfortunately, where do you live, Dr. Prakash? In
Sir,
Hyderabad?
sir, I am in Kadapa of Andhra Pradesh, sir, near to.
Kadapa, okay, in Kadapa district. But if you go to metropolitan cities like Chennai, Hyderabad, or
Yes, sir.
Delhi, or Chandigarh,
Yes, sir.
I, as a patient, can walk into a super specialty hospital with simple fever, cold, and cough.
Sir.
Nobody will stop me, and they are bound to give me treatment. At the same time, at the primary healthcare center, people go with cancers, people go with emergency conditions where there are no treatment facilities available. As a result, what is happening? In a tertiary care hospital, they are becoming overcrowded. If 1,000 patients come to an OPD, out of that 700 require primary health care and 300 require specialized care, then these 700 people are eating up the time of the doctor, which could have been given for those 300 patients who require specialty care. If these 700 patients were taken care of the primary hospital, that is not happening. Why?
Yes,
Because we do not have a referral system.
sir.
And the third important thing is multiplicity of agency. I
Sir.
can hold an ESI card and I can go to Ayushman Bharat scheme.
Sir.
Okay. I hold a private insurance and I can go to a government hospital and demand free treatment. Now, this kind of multiplicity of agencies, there are no regulations, there are no categorization of systems that hampers delivery of healthcare.
Sir.
So, if you look at this way, I see these three primary challenges. If we can set these challenges right, we develop a robust referral care system. We make the services so lucrative that the doctors themselves volunteer to go to the rural area. And
Sir.
third, we regulate the multiplicity of agency. If you are covered by one system, you cannot jump to the next system. If these three reforms are made, our existing healthcare system can become wonderful.
Thank you, sir. Thank you for your insights.
Sir, one more small comment from my side, sir.
Yes, sir. Please go ahead.
Government has to put this health on the priority sector, because as
Absolutely.
you know, the percentage of GDP spending on the health is just 2.1% by
Yeah.
2020-21. It was supposed to reach by 2.5% by 25, but the data is not released as yet.
Yes,
Compared to the US, which spent 16 to 18% of their
that's right.
GDP. And as you have already put on the PPTs also, most of the European countries is reaching 12% of their
12%.
spending.
Absolutely. Yeah.
So if this is very minuscule percentage of GDP being spent on the health, and that gives a leverage for the private sectors to come in and obviously they will have their own way of doing the medical systems.
Exactly. Very
So
rightly said, sir.
yes, sir. Yes, sir.
Okay, so if there are no more questions, I can shift to the last segment. And in the last segment, we will talk about the the final part, that is the final module in your this block is international organizations working in the health sector. So in international organizations means those agencies which work across countries and help in the delivery of healthcare in many countries through single organization. So the first organization that comes into play is the United Nations organization, what we know as UNO. UNO has its different institutions which take care of healthcare in different countries. We will see a little bit of detail after that. And then we have international non-government organizations. And then finally, we have philanthropic organizations. The smaller bullets, I'm sorry, they're not part of philanthropic organization. These are, the slide is a little disorganized. These are examples of United Nations organization. First is World Health Organization, as you know, is the apex body of managing managing the health of the citizens of the whole planet. World Health Organization, all of you are familiar with. This is a UN body set up by the UN Charter, and all members of the United Nations organization are committed to contributing to sustaining of WHO, and WHO becomes the guiding resource for managing healthcare, that has an advisory role in managing healthcare across the world. Very recently, United States of America has opted out of WHO, and as a result, the funding that comes to WHO has to be downsized. The second UN organization, which was set up in the after the as a part of the UN Charter, was to take care of the global children. Remember, the post World War, Second World War era, the global South and some of the other countries had very high infant mortality level, poverty, hunger, diseases, and mortality among children was very high. So to take care of that, United Nations had set up a United Nations International Children's Emergency Fund. The acronym of that was UNICEF. Now this has been changed to just United Nations Children's Fund. The emergency has been brought for that. These are the two organizations of the United Nations which directly uh, provide healthcare services or management of healthcare services in terms of policy making, guiding principles, regulations, international health regulations, and taking care of children's health need is done directly under the umbrella of United Nations. The other agencies, like United Nations Development Program, United Nations Family Planning Program, United Nations Commission on Refugees, FAO, that is Food and Agricultural Organization, and International Labour Organization, they indirectly contribute to the healthcare system. For example, ILO is responsible for taking care of employees' benefits in different countries, that looks after the employees' healthcare benefits and other benefits and guides countries in following that. Food and Agricultural Organization helps in improving the produce of the food, maintaining these food and safety standards across the world, and helping production of local food items and processing of food items and all that. So these are the agencies under United Nations. Under international organizations, besides United Nations, we have international NGOs which work globally in different countries. Some of the well-known agencies are called, like, for example, Doctors Without Borders or Medicine Sans Frontiers. And then we are familiar with Red Cross, International Committee of the Red Cross. And also there are other organizations, for example, in international NGOs, we have different charitable organizations which originated in one country, but they are working in multiple countries. And then, for example, we have CARE, Center for American Relief Everywhere, which is an American NGO, which is working all over the world. USA, United States Agency for International Development. Then we have in JAPIGO. JAPIGO is about JHIPIGO, Johns Hopkins Institute for Gynecological and Obstetric Services across the world. So there are many NGOs which, on a not-for-profit basis, support the healthcare delivery system, particularly of those countries where the government is not able to provide the highest level of healthcare, or the local systems are not efficient enough to take care of the entire healthcare need of the country. So these NGOs provide a supporting role. And then philanthropy means large business houses, corporate sectors, which have additional funds available. They have created funds for improving the healthcare delivery and health of the people, especially in developing countries and poor economies, where the government themselves are not capable of meeting the healthcare need of all countries. So there are funds like GFATM, which is known as Global Fund to Fight AIDS, Tuberculosis, Malaria. There is a Gates Foundation, which was earlier known as Bill and Melinda Gates Foundation, which provides a lot of financial support and also plays advisory role in fighting different diseases in different parts of the world. And then we have a Global Alliance for Vaccine Initiatives, which preliminarily works towards development of new vaccines and ensuring distribution of vaccines in the deprived countries. Besides that, there are other organizations where health is a core activity. That means World Bank, International Monetary Fund, Asian Development Bank, though they are primarily global banking agencies, but they give dedicated funds for healthcare services in countries, or sometimes when they give loan, soft loan to the developing economies, they link the loan with the healthcare sector. That we will provide you fund for development only if you meet these following parameters of healthcare. One of the example is that India, when it needed large amount of loan, so World Bank gave a loan saying that the loan can be utilized only if you work towards improving elimination of tuberculosis, improving universal immunization. A part of the loan has to be used for strengthening these services, then only development loan can be given. International Monetary Fund and World Bank also carry out audit and analysis of healthcare requirement of different countries and accordingly advise the government on utilizing the economic resources for improving the health of the people. So that is how, despite being banking agencies or financial agencies, they also work in the field of health to improve the health globally. Now, World Health Organization, can be a question in your examination, so you should read that in detail. As I already said, this is a UN agency which is responsible for prevention and control of specific diseases, development of they help in developing national health policies, they help in forming international health regulations, and they compile statistical data of health globally and share with the countries so that those data can be utilized for improving healthcare services. It works through World Health Assembly. All member countries of the United Nations are members of the World Health Assembly, and they participate annually and take up issues related to health. Then there is an executive board, and then there is a secretariat which is responsible for functioning. And WHO has zonal organizations or regional organizations, regional offices. 7 regions are there. India falls under the Southeast Asia region. Then there is a region of America. Then there is a European region, Northwestern region, like that. There are 7 regions, and all activities are carried out through the regional offices. And within regions, every country has a office of the WHO which helps with the local government. The other agencies, UN agencies, you can read from your module or from other site. That will be very helpful for you preparing for your exam. So that is all from my side. And once again, if there are any last minute thoughts or questions or anything that you want to share or discuss, feel free to do so. We have about 5 to 7 minutes time.
Really, sir, we are very thankful to you. Our sincere gratitude and thanks. It was very lucid and presentation was very clear. Obviously, we'll have to read it further and then
Yeah.
only write in the exams. And hope RC Delhi is listening. Dr. Sharma sir should have been in our counseling mentors for other sessions also. This was my
Thank you for your kind words.
sir.
If there are any other questions,
I served in army for 30 years, sir. And a lot of doctors were from the UCMS also.
I see.
One of the doctor, he turned to be IPS officer and he was here SP in Ranchi also, sir.
Okay.
Dr.
Yeah,
Prabhat.
a lot of doctors from UCMS have got into civil services.
Yes, sir.
In foreign services also.
Yes,
So
sir.
that is true.
Yes, sir. I served in Army Hospital, Delhi also myself,
I
sir.
Okay, RNR, in RNR hospital.
Yes, sir.
Right. Right.
Superannuated in 2013. So it was very, very nice interacting with you and we'll keep in touch.
Thank you so much, sir. Thank you. All the best to you and all the participants. Have happy studying. Thank you. I'll take leave.
Thank you, sir.